of two schools. Ma'am, I request you to take over the session.
A very warm welcome and greetings to all, and my respects to all the teachers who are present here too. We are three adolescent team who come from Vellore and Ranipet, and this is Dr. Mona Bhaskar, Professor of Pediatrics from CMC. She's been trained in Toronto in Sick Children Hospital for some time, and she's joined CMC back, and she's the professor presently there. And that is Dr. Shri Priya, Chief Civil Surgeon, and she's been involved in adolescent medicine and general practice, and she is in ESI Hospital, Vellore. With a small introduction, the scope of today's panel discussion is to know the magnitude of the adolescent issues and our health burden, and how do we approach the adolescents in our clinic. It will be a bird's eye view, and also a few practical solutions to adolescent problems as a small clinical presentations here. So India has the largest population of adolescents, about 253 million, and every fifth child will be an adolescent here. Not only that, they form almost 50% of the adolescent population who occupy the Southeast Asian nation and also the sub-Saharan regions. If you see the magnitude of the mortality, most of it is preventable. The unintended injuries, homicide, suicide, they form the most part of it. And the rest of it is the routine along with the other population. Along with that, we have mental health issues and NCD, non-communicable diseases, which has its onset much earlier in adolescence, which is going to add to our burden. So with this introduction, I would ask Dr. Mona to do her first case. And before that, when the adolescent come to our clinic, we have certain rules to follow: confidentiality, consent, chaperone, legality. Confidentiality is something we have to tell our adolescent. Adolescent is going to be our patient. We have to gain the trust of the adolescent and tell the adolescent that whatever the adolescent is going to tell us will be kept confidential, except in few scenarios where it can harm the life of the adolescent, like in suicidal ideation or any kind of violence and sexual abuse. There may be some other conditions too, because in India, the children are mostly dependent on the parents for all their requirements, and the parent also pays for the fees. Consent, it's very, very important. We take the consent, oral consent for the examination of the adolescent, and we must have a chaperone to examine the adolescent, whether it is a female or a male. Regarding the legality, we just have to know few things here, and then later we need to probe and learn much more about it. All persons less than 18 years are considered adolescents, children, and we must be aware of POCSO law. Any child or adolescent who is going to complain about any kind of violence or sexual abuse to us, it is the onus on us to go and report it immediately to the police, or you will be taken to task. And also there are other laws pertaining to child rights, which we must understand. What we do in the clinic is apart from the medical examination, we are going to do the head's psychosocial review, which is going to be a brief interviewing and spot the strengths of the adolescents, emotional well-being. Is there any high-risk behavior, or is there areas where we need to intervene? HEADS is nothing but the acronym of home and environment, education and employment, eating and exercise, activities, drugs, sexuality, suicide and depression, safety. We can add more depending on the needs of the adolescent. In India, we have added the extra thing as spirituality. Next slide. So the first case will be dealt by Dr. Mona. You can ask questions at the end of the session. You can make a note of it. Thank you.
Good evening, everyone. We'll start with two similar cases to a particular disease and common among adolescents. The first is Ramu, a 12-year-old boy from Vellore, who came with history of noticeable, significant weight loss over the past 2 years, severe restriction of food, and he also used to induce vomiting every time he ate, and he was obsessed with exercise soon after eating or even otherwise. And the trigger was he was being teased about being overweight. On examination, he had pallor, he had no cyanosis, clubbing, lymphadenopathy. His weight was very low, it was less than the 5th centile, and BMI was 13.3. By the WHO BMI centile, it was less than the 3rd centile. And heart rate showed significant orthostatic changes. While supine and standing, there was a significant difference in the heart rate. Other systems examination was normal. Next slide. He also had soft hair, what we describe as lanugo hair in preterm infants, which is typical in this condition over the face and chest. He also had dry skin, and oral cavity showed petechiae and some ulcers because of the repeated vomiting. Systems examination otherwise was normal. The second is a 9-year-old boy, Fazil from Bangladesh. He also had progressively decreasing appetite, eating followed by vomiting, severe loss of weight, and he appeared to be more withdrawn and depressed over the past 2 years. Next slide. He too had pallor, and there was no other significant finding, apart from peripheries being very cold. All peripheral pulses, however, were well felt. His weight was low, BMI was very low, 10.3, again by the WHO centiles, it was less than the 3rd centile. His heart rate and blood pressure were all right, meaning there were no orthostatic changes. Respiratory rate was all right, temperature was also all right, systems examination was normal. Investigation showed that Fazil had anemia and hypokalemia, and both had vitamin D deficiency, and other investigations were grossly normal. X-rays showed what is typically seen in this condition called microcardia, generally taken as less than 40 to 42% of cardiothoracic ratio. He had a smaller heart. Ramu's heart was not that significantly affected. So, next slide. So both these X-rays show severe osteopenia and definite microcardia in Fazil's X-ray. Next slide. So a diagnosis was made of anorexia nervosa. The first boy had a restricting type. There are two types of anorexia nervosa. The first boy had restricting type, and the second boy had a binge purge type of anorexia nervosa. Going on to eating disorders. These are characterized by a persistent disturbance of or disordered eating that impairs overall physical health, psychosocial health. It is primarily a psychiatric illness, but with significant effects in the physical body. Included in this is, can you go back? Is anorexia nervosa. Go back to the previous slide. According to DSM-5, which is latest from 2019, it is called feeding and eating disorders, this bunch of eating disorders, and anorexia is one of those. The others are bulimia, binge eating, pica, rumination disorder, and RFID, avoidant restrictive food intake disorder. Next slide. Studies have shown that in the US, in a nationally representative sample of 13 to 18-year-old adolescents, the lifetime prevalence of anorexia nervosa was 0.3%, and that particular study showed that the prevalence was equal among boys and girls. From India, there are some studies. One showed that the combined gender burden for anorexia nervosa is 22 per 100,000 population. And most of the burden was borne by women in the 15 to 19-year age group. And this Indian study again showed lesser males and females than females affected by anorexia nervosa. AN is diagnosed by DSM criteria, 5 criteria, which should include all 3 criteria. Definite restriction of food intake, energy intake, intense fear of gaining weight, even though they may not talk about a fear, there's persistent behavior that prevents any weight gain, and a distorted perception of body weight and shape, and the weight controlling their way they think about themselves, their self-esteem, self-worth. Next slide. So studies have shown that in the brain there's anatomic abnormalities, and even in the neurochemical transmitter systems there's definite abnormalities among adolescents with anorexia nervosa. Previous slide. So there is an abnormal anatomy of the corticolimbic tract and the dorsal striatum, one of the basal ganglia, in patients with anorexia nervosa, and even a locus has been identified on the chromosome 12, which is typically associated with anorexia nervosa. Thought patterns are particularly very skewed, distorted in adolescents affected with anorexia nervosa. They all the time think that they are not good enough for anything, they don't deserve anything good in life. Next slide. These thought patterns are often obsessive towards calorie control and what they eat and how they lose the calories that they eat. So they keep talking about to themselves that you cannot eat that, you've already eaten, too many calories are there. You have to follow your own rules. Nobody can tell you to eat or not eat. Next slide. So if you can imagine this is a guy with anorexia nervosa, typically very emaciated body. And if you can imagine, this is a girl who has anorexia nervosa, but their perception, if you can imagine, is that when they look at themselves in the mirror, they look at themselves as somebody overweight or obese. So that is something difficult to understand for a person who does not have anorexia nervosa. Looking at medical complications, almost every system in the body is affected. Gastrointestinal, lungs, liver, hematopoietic system. Next slide. Cardiovascular system, gynecological system, the reproductive system. Go back. Go back. Endocrine system. What is important to remember is all these complications reverse back to normal once a patient with anorexia nervosa is successfully treated. The one thing that does not reverse or has irreversible damage is the bones. So for life they are prone for fractures. Next slide. There are several screening questionnaires for eating disorders. This is one of the shorter ones called SCOFF, where one question, if the patient says yes to it, indicates that probably there is an eating disorder. Next slide. I just want to say the principles of management in anorexia nervosa. For about 7 or 8 years we've been managing in our center in Vellore. What is required is a multidisciplinary team, including a pediatrician, adolescent or an adolescent medicine specialist, child psychiatrist, definitely a dietitian, psychologist, a nurse and a social worker. You start off by stabilizing the general medical status when they are having electrolyte abnormalities or hemodynamic instability, going on to restoring weight and normal eating pattern, and finally regain the ability to perceive, to understand hunger and satiety. We start off by calculating the target calories for that particular patient based on the trajectory according to what they were earlier in life, according to their height and age, and then generally start calories at 2000 calories to start with that treatment. We have to monitor for refeeding syndrome, which is a very dreaded complication while starting calorie intake. And of course, all the psychiatric management, CBT, cognitive remediation therapy, family-based therapy, motivation and interviewing, in addition to psychotherapeutic drugs. Duration for recovery usually takes about a year, and typically we talk about 3 phases in the stages of recovery.
Thank you, Dr. Mona. The next case is in the periphery, in the clinic. So this is Miss Divya, age 15 years, female, brought by her parents for increased sleep, lack of motivation to study, frequent quarrels with the siblings. So in the clinic, medical examination is done and also a health review is done. She comes from a home where it's a nuclear family with 3 siblings, and she studies in 10th standard state board school. She does not eat well, sleeping most of the time, reluctance to do any kind of physical activity, and she is engaged in cell phone most of the time. No hobbies, no outdoor activity. Regarding her sexuality, she had been having romantic relationship with a boy, senior in her school, and spends time talking over the phone most of the time. No physical contact till now. On further review, she said that she did not have any physical intimacy with the boy. Suicide and depression. She had low mood, not motivated to do anything, no appetite, irritable with parents and siblings. Usually the quarrel with the siblings is they eavesdrop and go and tell the parents about her talking with the boyfriends, or they do not give the cell phones. Her academic performance was falling, and She was cutting class and there is no suicidal ideation in this patient. She is totally unaware of any kind of safety. Next slide. So regarding this Divya, her core issue was her romantic relationship with the boy. So taking this review, we took this opportunity to counsel Divya regarding her infatuation, that it is only normal to fall in attracted to the opposite sex, and also it is biological and natural. The other things we saw was, next slide. We did a big depression inventory and was found to have mild to moderate depression. Next. So her medical condition was treated for anemia, moderate depression. Her romantic relationship issue was also spoken to the parent as well as herself, and all these physiological facts were told to her. She was counseled regarding her self-care, responsibility at home, and sibling conflict resolution. Also, she has a task to perform. It is not only that natural to be attracted to the opposite sex, but she has other tasks to be fulfilled regarding her studies and taking part in extracurricular activities. And counseling on early risk behavior also was told to her, the risk of sexually transmitted infections with unknown person, and also real life situation, what could happen in case she becomes pregnant. She was counseled regarding life skills, that she should have the ability to be aware of herself, and also problem solving skills, decision making. She needs to think critically and really cope with her emotions. This is only the gist of the case that we have dealt with at the periphery. Case 3 is by Dr. Shripriya.
Here we have 16-year-old Advait who changed to a new school for NEET coaching after his 10th standard examination. During COVID restrictions, the classes were initially online and he managed to get decent scores. And once the school reopened a month back, he found it very difficult to adjust to his new classmates and teachers. He used to sit alone most of the time with decreased interaction. His performance further declined. In this context, he had intermittent sleep disturbances, episodes of crying, anticipatory anxiety towards his future exams. On Head's assessment, he had working parents who followed authoritarian parenting. He was a single child, and most of the time he used to eat in front of the TV, no family meal, and he used to take a lot of junks, especially during this COVID lockdown. He was a high achiever in his previous school, no regular exercise, and sleep disturbances after starting the new school. His BMI was 26 percentile, he was overweight, and he looked distressed. Systemic examination was normal. All his symptoms were of recent onset, only secondary to the stress. Though both the symptoms of anxiety and depression both were present, the presenting complaints were not to the extent of an anxiety disorder or a depressive disorder. A diagnosis of adjustment disorder, which is a stress reaction, was made. After hearing in the previous session from our president about managing pediatric stress, how we are going to manage this adolescence stress. Allow the child to talk with active listening. That is, listen with all your heart, with eye contact, without interrupting and without being judgmental. Clarify the current stressor by repeating what you understand the central idea of the emotion is and to what extent it causes the distress. Clarify for other stressors. In this case, it may be the dominant parenting, high expectations from the parents, single child, or overweight issues, or even bullying in the new school. After providing empathetic support and after allowing the child to talk, educate the child to orient all his actions towards working on his future goals. Identify and replace his negative thinking with more realistic thinking. Next. Teach him coping strategies, which is the main goal of treatment. Lifestyle modification, healthy diet advice, at least one family meal per day, and the junks to be limited to only once a week. Regular physical exercise for 1 hour per day. Relaxation strategies will help this child a lot. That is deep breathing, which is diaphragmatic breathing. Teach the child to take a deep, slow inspiration, hold the breath, and a slow expiration so that the abdomen goes inside. This will cause the parasympathetic system to slow down, and this will also helps to regulate the somatic dysregulation. Next is the Jacobson's progressive muscle relaxation exercises, which are popularly known as the JPMR exercises. In this, the child can do it either in the lying down or sitting position. In a sequential manner, the child is taught to contract and then relax the muscles, various groups of muscles, in a concentrated manner, focus and without any external disturbances. Then in overwhelming situations, the child can go on a self-guided imaginative journey, the guided visual imagery. This, the child can be taught to go in their minds somewhere else and calm down. This is an example of a narrative for a guided visual imagery. The scenario can be a forest, mountain, garden, beach, wherever the child likes, or even stargazing. Previous. Meditation is a wonderful tool. It puts the brain into cold cognition, makes the child to focus on one thought. 20 minutes of meditation per day does wonders. Mindfulness meditation can be followed using apps like Calm, Headspace, etc. Then educate the parents about the insight into the illness of the child and about the change in the style of parenting, which will be dealt later in the future sessions, and effective communication, increase the parental connectedness, and also have realistic expectations. Then the progress was being monitored, and during follow-ups, life skills training were given with special impetus to the skill in which the child lacked and which led to this problem. Over to Vijayarani ma'am.
This is another case, 17 years Shweta from a very conservative middle economic status family was brought by the mother with complaints of pain in the perineum for the past 2 weeks. On examination, apart from all the other medical examination, she was done a genital examination with the chaperone, with her consent. She had vesicular lesions around the vaginal orifice, 1 or 2 ruptured and ulcerated, which had given her the pain. So a clinical diagnosis of HSV2 infection was done, and few blood tests were asked for. The one is the routine screening for syphilis and HIV, and also IgM, IgG for HSV2. And the case was managed with acyclovir treatment, and she was given some more counseling regarding this. She was counseled about her sexuality issues and the risk of sexually transmitted infections, and what would happen if she is further engaging in physical intimacy with anybody. Her problem was just one exposure with physical intimacy with her brother of a friend had created this problem. She acquired this infection. Regarding HSV, it is lifelong. It has no cure, but it comes in exacerbations and remissions. So it can create a lot of anxiety to the adolescent. It must be treated on and off. So she was made aware of this. Also the treatment, we do the syndromic management of STI based on NACO and WHO. This particular case, genital ulcer syndrome, and depending on the number of ulcers, if it's single, usually it is syphilis or chancroid, pain and painless. Multiple, you think of syphilis, chancroid as well as HIV, HSV2. And on treatment, if it's treated and if she feels better, no need to refer, otherwise she needs to be referred. The problem with adolescent STIs are that they have higher rates than other older adults. More partners, they have more partners, and the relationship is very short. And they feel very embarrassed to obtain contraception. So again, the preventive aspect is very tough for the physicians to deal with. They do not recognize the risk of STI, lack of knowledge on symptoms, where to seek help and care. And they find it very difficult to refuse sex, especially the girls. They think that is the only way to show their love and affection when the boy asks. And they cannot afford the health services, unlike in the developed nations like the Scandinavian countries, where they can walk in and ask for whatever kind of help they need. Here they come with parents or maybe some friends with some help. So, and also only now we are developing the adolescent clinics. Over to the next case by Shri Priya.
Now we have 14-year-old Neha studying class 9 with history of repeated episodes of cutting her forearm with a blade. She says she does that when she feels sad, now because her close friend refuses to talk with her. She has also expressed a desire to die to another friend, saying, "Nobody likes me, why should I live?" Head's assessment showed working parents, marital conflict with neglected parenting. Her appetite was low, she has less interest in studies, and she was feeling fatigue throughout the day and was also having feelings of worthlessness. She could not sleep throughout the night and had daytime sleepiness. She had suicidal tendencies. Next. Beck depression inventory can be used in a school setting and can be even administered by non-clinicians to screen for depression. Next. 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 In this case, Neha's sad mood along with sleep disturbances, poor appetite, feeling of worthlessness, loss of energy and thoughts of suicide. All this made her fit into a criteria for major depressive disorder. Next. So how can we help this Neha? Recognize the signs for suicidal risk. From what you hear from the teen may be saying, "I want to die, I want to kill myself, I wish I was dead." From what you see, she can be looking numb, withdrawn or apathetic, or what is happening to her. She may be having feelings of worthlessness, feeling of hopelessness, feeling of helplessness. All these three things have a high risk for suicide. And also having a definitive suicide plan has a high risk for suicide. Sometimes the teen may also be collecting tools for weapons for conducting the suicide, like collecting ropes, knives, etc. This also has a high risk for suicide. So ask directly for all these things. Allow the teen to talk about the reasons with active listening. Acknowledge saying, "I can understand." Validate the pain and say, "It is good that it is very difficult to verbalize all these things. I appreciate that you chose to verbalize and talk to me." Do a safety check regarding the ideal setting to manage the patient, in this case, which is a hospital. Psychoeducate the parents regarding the insight into the issue or the need for emergent psychiatric care. Connect to a psychiatrist. Next is the pharmacotherapy for depression. Selective serotonin reuptake inhibitors are the drug of choice. First choice is fluoxetine, next sertraline, and then escitalopram. Next. So when to refer a child with depression? Presence of suicidal tendencies, substance abuse, no response to treatment, and relapse of treatment. All these are indicators for referring the child.
As we get the questions, Dr. Shripriya, is it okay we ask directly to the adolescent that whether the patient has suicidal ideation?
Only if we question, we'll be able to recognize the risk factor early. So it's usually a myth that if you ask, then it will instigate the suicidal thought, but there is no evidence for that. Always ask directly for suicidal risk, suicidal tendency in a depressed child.
And how do we recognize eating disorder at the periphery level?
So basically we need to educate all the healthcare professionals and school authorities, people like the coaches who take care, teachers, all of them who take care of teenagers, that there is something called an eating disorder, and always a significant weight loss in a short period of time is a red flag for eating disorders. So any teen with a low weight who has lost weight over a short period of time, suspect eating disorder and refer.
Yes, sir. Yes.
You say and sway is there, and I think many of our colleagues, children also commit suicide. Okay. So how do you see? They normally suddenly they come back. Really do not know. Really, it's sad even. Doctors' children, dying of doctors, adolescents pediatricians dying. How do you? I can't understand. Normal, suddenly next day morning, how can you expect? Suppose somebody is depressed, say failing the exam, failing the leave, then you may give some requests. So, giving normally suddenly don't hang it.
Symptoms, subtle symptoms will be seen, sir. Just in teenagers, they may just show anger or a negative predisposition, or they may just avoid social interaction, or they may be doing certain self-harm behavior. Many subtle symptoms will be seen. Even if only one symptom is seen, it is always better directly to ask questions. That is why whenever there is a depressed mood, it is always better to directly question the child if they are having any tendency, if they feel like dying, if they have any tendency to hurt or dies.
I would like to add to your question, sir. That is why WHO has brought this life skills of self-awareness and decision-making, problem-solving, coping with emotions and stress. Also the connectedness, there are the various positive factors, the connectedness with the family, the parents. If that is strong, so there will not be such impulsive suicidal rates in our country. And the other thing is, there are certain things which you can't help, like endothymic depression, where they are very much prone for suicides. Those things we cannot help. That is out of our domain. Thank you, sir.
Thank you, madam. If there are any questions from the audience? Yeah. Thank you, ma'am. Thank you, ma'am, for your wonderful talk. And it was a new for many of us who are not seeing day-to-day adolescent issues, but we learned a lot from you, ma'am. Thank you. We'll give the mementos, ma'am. Dr. Vijayarani, ma'am, I request you to give the mementos to the other speaker, Dr. Mona Bhaskar and Dr. Sri Priyam. Dr. Mona Bhaskar. Dr. Sri Priyam. I request Dr. Mona Bhaskar to give the memento to Dr. Vijayarani. Thank you, ma'am. Our next session is a talk by Dr. Indra Jaikumar, which is chaired by one of our senior colleagues, pediatrician from Pondicherry. I invite Dr. P. Sriram and Dr. Indra Jaikumar to chair the session. Dr. P. Sriram. Sriram sir was a senior colleague of mine. He is now the professor and HOD of Indira Gandhi Medical College.